So, good morning, good afternoon, good evening to everyone who's joined us. Welcome to the World Diabetes Foundation Anniversary Online Forum, where we'll be discussing the power of partnerships towards better diabetes care and prevention. My name is James Eustace. I'm a partner and I'm co-lead of the Global Health Practice at Dalberg, and I'll be your moderator, guiding you through the session today. So let me start by giving you a bit of context to why we're here today. Since its inception 20 years ago, the World Diabetes Foundation has been working in partnership with local champions, national governments, diabetes advocates, and international organizations to create innovative and sustainable solutions for people with diabetes and to strengthen healthcare systems in low and middle income countries. The past 20 years have brought positive change with a significant increase in attention and investments in diabetes care and prevention initiatives, and with the establishment of strong partnerships and networks to set the global policy agenda on non-communicable diseases. While we should mark these achievements and learn from them, the continuing growing burden of NCDs and resource challenge has really increased the call for civil society and non-state actors to contribute more to NCD prevention and care in support of national and global policies and frameworks. So now more than ever, innovative partnership models and sustainable investments are needed to reverse the rising tide of diabetes and NCDs. So this is exactly what we will do at this convening today. We'll reflect on the past 20 years of learnings and collaborations, and also discuss the ways forward to accelerate diabetes care and prevention. What you're seeing in front of you is an overview of the agenda. We have a remarkable speaker lineup and some fascinating topics for discussion. We'll spend the next hour discussing diabetes care and prevention in a changing landscape, and hopefully sharing some lessons with a special emphasis on the power of partnerships. Now, as you can see from the agenda, we've got some exciting sessions to go through, but we have a really short time. And I'll therefore really encourage our speakers to keep on time and hopefully make sure we have sufficient time for all the insights prepared by the speakers, as well as many questions from the audience, we hope. Just to note also, I will do that awkward thing of interrupting speakers with a short time warning if needed. So I just pre-apologize to anyone if I have to do that. Some quick pointers on housekeeping. I really encourage all participants to make use of the online forum. Ask questions, share comments throughout the entire session via the Zoom chat, which you can see at the bottom of your screen. It's open throughout the event, and I'll be directing some selected questions to our panelists when the time comes. The online forum is live, so feel free to share any thoughts or comments that arise from the discussions on social media using the hashtag WDF20. And just a quick note, the discussions will be recorded and disseminated on social media platforms after the event. So let's move to our opening address. It's really my pleasure to present Dr. Anil Kapur, who is chairman of the board at the World Diabetes Foundation, who will open the forum by setting the scene for today's discussions. Dr. Kapur has been associated with the WDF since its inception in several leadership roles and was elected as chairperson of the board in 2015. As many of you no doubt already know, he is a renowned diabetes expert and advocate on the link between maternal health and NCDs. Dr. Kapur will be opening the event by sharing his key reflections along the path of partnerships and setting the course for diabetes care and prevention in a changing landscape. So it's my great pleasure to hand over to you, Dr. Kapur.
Thank you, James. And I'd like to add my welcome to all the participants and especially the panelists on this session webinar. And as James mentioned, the issue of NCDs and diabetes is becoming quite grave and significant. And therefore, it would be very nice to have an overview of what the World Diabetes Foundation has been able to do in the last 20 years, but also looking forward to what is required to be done. So the WDF set out on a journey in 2002, guided by a vision of alleviating human suffering related to diabetes among those in the greatest need, by putting diabetes and NCDs on the agenda in low and middle income countries, and doing this with local, regional, and global partners. Basically, if I may have the next slide, the focus of the World Diabetes Foundation has been catalyzing change and in terms of trying to help others do more. And this has been done through capacity building and empowerment, wherein we have ensured that our partners at the local, global, and regional levels develop the capacity to be able to undertake these initiatives on a larger scale as we go by. And most of these projects are locally owned. So it is not something that the World Diabetes Foundation has imposed upon our local partners. These projects are owned locally and are driven locally by our project partners. We have ensured that through our funding, we have been able to leverage resources to enhance the sustainability of the initiatives by ensuring that we do these projects as far as possible within existing health systems and do not create parallel initiatives, ensuring that the partners have the capacity to be able to then attract other sources of funding and strengthening local health systems, leveraging the local health systems to be able to ensure that there would be sustainability going forward. And the third important point that has been a real focus of the World Diabetes Foundation is to identify issues that are so relevant for the vulnerable populations and things that have been neglected in the past. So for example, starting focusing on prevention of amputations because of diabetes, to prevention of blindness because of diabetes, to moving on and talking about issues that link diabetes with communicable diseases. And as we have seen in the last 2 years with the pandemic of corona virus, that infections and diabetes are very closely linked. So we started working with the area of tuberculosis, where we tried to attract attention of the International Union Against Tuberculosis and Lung Disease and the WHO to start thinking about the double burden that diabetes and tuberculosis causes in the middle and low income countries, or ensuring that we understand the linkages between maternal health and the issue of NCDs, wherein maternal health drives the issue of NCDs, and poor maternal health is responsible for NCDs going forward. So that's an important agenda that we have been driving forward. If I may have the next slide, please. So over the last 20 years, if we look at it, if we look at our journey, we can divide our journey into kind of 4 parts. Initial years were the founding years. And in these years, basically, it was starting with small local anchored projects from the grassroots level, starting with a simple thing like a container clinic in Tanzania, and Dr. Kaushik Ramaiya would be talking a lot about Tanzania and how we have progressed from a simple container clinic to now supporting and working with the Ministry of Health in terms of creating and the development of a NCD program in Tanzania. The subsequent years was between 2010 and 2015, where we learned from these initial grassroots initiatives. We were able to understand the feasibility of doing these initiatives and then moving on to expanding it on a larger scale with involvement of more networks. And this included ensuring that we were able to work with large international organizations and professional organizations, and ensuring that there was partnership at the ground level. In the subsequent years, as we move forward, we do realize that we cannot address NCDs without ensuring that there is universal health coverage. that there is adequate financing available to be able to deal with NCDs, because that has been a neglected area for many years. And that is why we have then moved on to becoming a convener and a change agent, where we have tried to get together international stakeholders onto a similar platform to talk about issues such as universal health coverage, integrated primary health care, and ensuring that funding available to address these issues. And this has also involved working with other professional organizations such as the International Federation of Obstetrics and Gynecology, the International Union Against Tuberculosis and Lung Disease, agencies that are working in the area of eye diseases, and bringing them together to be able to address some of these issues. And going forward, it is our desire, and that is what we are trying to do, is to be able to get more funding into the area of NCDs, to ensure that NCDs were part of the strengthened primary healthcare system, and also that there was an integration, between maternal child health and communicable diseases and non-communicable diseases, because in the past we have worked in silos, and these silos don't actually help in terms of delivering prevention and care in terms of what the patient needs. We might divide diseases, but the person that are affected by it are the same. And therefore, looking at it from a more comprehensive way is what we are looking forward as we move on. Next slide, please. If I may have the next slide, please. Yeah. So in the last 20 years of improving lives together, a lot has been achieved. Over these last 20 years, the World Diabetes Foundation has funded, I guess I'm right, around 580 odd projects in 119 countries around the world. And these projects have resulted in significant changes in terms of patient care, in terms of addressing prevention, in terms of building capacity for integrated care. And over about 8.6 million patients have received support and care through capacity built by the World Diabetes Foundation projects. And these are basically numbers that I'm talking are only during the project duration. A lot of this continues to happen even after the project have been completed. Almost about 14 million people have been screened for diabetes, and about 550,000 healthcare professionals have been trained, and over 20,000 clinics have been established to be able to provide care for diabetes and related NCDs. As we go forward, our vision, as I mentioned earlier, is to ensure that care and prevention work in tandem, and that it is an integrated approach to care and prevention, basically through strengthening health systems to sustainably improve diabetes care and prevention, and use it as a starting point or as a nidus to build services for larger NCDs, and ensure that the services that are built for diabetes are also available for dealing with other NCDs in the given healthcare setting. Also, in terms of addressing prevention, we need to not only look at the determinants of health and risk factors, because these are common soil hypotheses that many of the NCDs originate from similar risk factors, but also integrating things such as maternal health with NCD prevention. And this is an area that I'm particularly focused and interested in. And also the links between infections and diabetes in particular, because going forward, addressing diabetes will be able to help many of these programs that we talk about. And in many countries, maternal and child health and communicable diseases are very strong, and perhaps we could learn to see how we can adopt these programs on the ground to be also able to deliver care for diabetes. Now, a very important point from my angle as I want to close this opening remark is that building a system to address diabetes offers the platform to address other NCDs. There's no other disease, non-communicable disease, that can replace diabetes in terms of the ramifications and that it has and the links that it provides. So for example, the risk factors for diabetes are the same as the risk factors for hypertension, cardiovascular disease, etc. But also diabetes itself is a risk factor for many of these conditions. Diabetes is also linked to maternal health, and maternal health has consequences for NCDs as we go forward. Diabetes has linked to communicable diseases such as TB and recently what we saw with COVID-19. There is an immunopathy, and therefore people are at higher risk of infections, people with diabetes. So building a program around diabetes actually is a fundamental basis for building primary care in an integrated manner. And I think going forward, this has been one of the most important issues for us and will continue to be, as Dr. Kaushik Ramaiya will show later on, how starting with diabetes and building simple container clinics for diabetes have led Tanzania to now develop a very, very integrated NCD program. With that, I'll end my presentation, and I hope that we will learn much more from our partners who would be talking about what work they have been doing. So thank you very much.
Thank you so much for that, Dr. Kapur. I think that's really interesting, a terrific start to proceedings, particularly hearing about the power of partnership seen from the WDF's role as a convener and a catalyst to change. So thank you for that. Also, just a quick reminder for everyone, really encourage you to share your thoughts, share your reactions and questions as they come to you in the chat as we go through the session today. So it's now my honor to introduce our keynote speakers. So I'd like to start by introducing Dr. Omary Ubuguyu, who is the Director of Curative Services at the Ministry of Health in Tanzania. Dr. Ubuguyu also serves as a member of several working groups and technical committees on NCDs. Unfortunately, he can't be with us today, but has very kindly sent us a video message addressing how leveraging partnerships can help strengthen health systems. So I'll ask our events team to kindly show that message now, and then we'll come back.
Thank you so much for having me in this session. Minister of Health over the past 20 years have been improving on intervention on prevention and control of non-communicable diseases. But the hallmark on the change of these interventions started in 2019 when we established National Ncd Prevention and Control Program with the main focus of having a standalone program which focus entirely on NCD prevention. There's a little investment on non-communicable diseases. So on leveraging resources, we start to establish the chronic care clinic whereby people will be treated at the primary healthcare facilities. So we established a one-stop shop, and with that, most of the conditions such as diabetes, cancer, mental health, hematological conditions, and cardiovascular conditions are screened and treated. And on top of that, we established a collaborative mechanism with Prime Minister's offices, especially on a sector coordination, whereby we integrate NCD's intervention in almost all sectors, especially through Health in All policies and the other platform, whereby NCD's risk factors are addressed with other sectors. As we know, NCD risk factors, 80% lies outside of the health sectors. With this, we had a collaboration with a number of local and international organizations. To mention a few, we work together with WDF, Novo Nordisk, WHO, Tanzania Diabetes Association, and Tanzania NCD Alliance as key collaborators during the establishment of NCD program in Tanzania. Thank you, everyone, and I wish you a fruitful discussion.
Terrific. I think that was really interesting to hear about the concept, not only of the one-stop shop, but also the collaboration through the Prime Minister's office to work across several sectors. So on behalf of our whole team, really like to thank Dr. Ubuguyu and his team for sharing insights from Tanzania on that. So as we heard earlier from Dr. Kapur, WDF's first partnership project took place in Tanzania, starting with a container clinic, but since expanding much, much further. So to share the story about Tanzania's journey in building diabetes care, I'd like to now welcome Professor Kaushik Ramaiya, CEO at Sri Hindu Mandal Hospital in Dar es Salaam, and also Secretary General of the Tanzania Diabetes Association, amongst several other honorary appointments. He's played a crucial role in leading diabetes and NCD care efforts in Tanzania and elevating diabetes on the health agenda in Africa. So Professor Ramaiya, we're really lucky and grateful to have you with us. Professor Ramaiya will be talking to us about integrating health strategies and investing in building diabetes and NCD care in Tanzania. Over to you, Professor Ramaiya.
Thank you very much, James, for that kind introduction. And I would like to thank the World Diabetes Foundation for inviting me to give this talk. I'm going to basically present the story of Tanzania, of how we have established National Ncd Program, starting from a nidus of a diabetes as an entry point. And if you look at this slide, it will show you that over the last 20 years, and coincidentally 2002 is when World Diabetes Foundation was born. And first clinics which were established at that time were small container clinics, which was step one, whereby starting to learn how do we actually run these clinics, how do we establish a small clinics, and how do we make it effectively, providing a quality care. And based on the experience gained, we went to step two, whereby we moved from a container clinic into regional hospitals, trying to set up diabetes services at the regional hospital, and again, using diabetes as an entry point for non-communicable disease. And this included improving access to care. And it consisted of three fundamental entry points. One was training of the healthcare providers. Two, providing the infrastructure to these clinics to be able to diagnose and manage diabetes and other NCDs. And third, building the support services, or looking at the people with the disease and trying to establish the association and strengthen the association to make sure that this health system is accountable to the end users. Subsequent to this establishment of the regional hospitals and the regional clinics, the third step was starting to look at, although the burden of diabetes and non-communicable disease was high, the question was, how do we do the prevention? Because in the low middle income countries, cure might be there, but it is expensive. And what we need to look at is how do we prevent non-communicable disease, we prevent diabetes, hypertension, dyslipidemias, and we need to start with the primary healthcare programs. And school health program intervention was done. And subsequent to that, we started expanding to the district hospital level at step 4. So we had covered the zonal hospitals, the regional hospitals, and the district hospitals, and started collecting the data, understanding the problem, understanding the different components of the health system, where the challenges were. And based on all that experience, we now are at step 5, which includes taking care to the primary care, which is the health centers. But in addition to making sure that we take the care to the health centers and the primary care, we would like to institutionalize this program within the Ministry of Health, within the government, looking at prevention component, looking at the policy approach, and making sure that we have the right framework of policies so as to prevent the non-communicable disease and diabetes, ensuring that we do adequate health promotion so that people don't get into the disease pattern, and at the same time, looking at how do we actually integrate the chronic disease care model, which Dr. Ubuguyu talked about, whereby we have one-stop clinic at primary care clinic, whereby you can manage non-communicable disease, HIV, and we can manage diabetes and look at the integration of the services. At the same time, all this information requires implementation, research, and operational research to ensure that what you are doing is right. It is not affecting the quality, it is cost effective, but at the end of the day, it is providing the care required. Next slide, please. So if you look at this slide, and you will see that we started small with a small container clinic, which was a 40-foot container with 4 rooms, which basically started, and this model basically was less than $6,000 cost, which included the container, the air conditions, and the infrastructure. And with that small clinics, we started building up the diabetes care at the major hospitals in city of Dar es Salaam, in Zanzibar, and in Pemba. In addition to that, as I mentioned, we started training the healthcare providers, but the most important thing was that we had a partnership. The partnership was with the Ministry of Health, Ministry of the local government, and Diabetes Association, Tanzania NCD Alliance, and all the other stakeholders to ensure that whatever we are intervening, whatever we are doing is sustainable. Next slide. So in addition to integrating the services at the primary care level, at the secondary and tertiary care level, we found that most of the patients who were coming to the diabetes services also had hypertension, also had cardiac disease, also had concomitant stroke, had renal problems. So we started looking at how do we integrate all that component at different levels of primary, secondary, and tertiary care. And again, training and the training capacity, tools to train, and to ensure that we build the capacity of different levels, whether it is a community health worker, whether it is a nurse, whether it is a clinical officer, medical officer, or a specialist, is built at every level of the health system. And we also started looking at the early warning system, whereby appropriate referral system could be put in place. NCD surveillance and data gathering also started coming through, and we started looking at these different components and the data to make sure that whatever data is being generated, it is actually helping to frame up the policies, but at the same time ensuring that the NCD awareness is increased. Next slide. So what has been the way forward? We have managed to establish a framework for multi-sectoral collaboration. And in this slide, what you are seeing is the Honorable His Excellency, the Prime Minister of Tanzania, launching the National Ncd Program. As Dr. Ubuguyu mentioned, we have now a standalone National Ncd Program within the Ministry of Health, within the Ncd unit. And this program was launched in November 2019. The unique component of this program is that during the third week of November, from 17th to 14th of November, every year this program is basically implemented. We have what we call as an NCD week. And during this NCD week, all the NCD activities are carried out in regional, district, and the primary healthcare centers, and nationally. At the same time, we initiated the first National NCD conference in year 2019. And last year, we had the third NCD conference, which has been growing strength to strength. It is also enabling researchers, it is enabling the basic science researchers, operational research, implementation research, and the policymakers to sit down together and see how we can improve this program over a period of time. The coordination mechanism has been strengthened, and with the multi-sectoral component coordination sitting in the office of the Honorable His Excellency, the Prime Minister, the coordination of the different sectors, because as you know, more than 90% of the components of the NCD come outside the health sector. It is very important to have that coordination in place. We have managed to put in NCD advocacy, communication, and social mobilization strategy. And now we have a parliamentary committee which has got HIV, AIDS, substance abuse, tuberculosis, and non-communicable disease as a parliamentary forum within the parliament, which actually helps to move the policy agenda. We have got rollout of the NCD screening, care, and referral systems in place from the primary, secondary to tertiary care. And then most important is we are empowering the people with the disease to make sure that they play a very significant role in ensuring that what is being done is for the benefit of them, at the same time without compromising the quality of care. Thank you very much.
Thanks, Professor Ramaiya, so much. That was extremely interesting and really insightful. But perhaps before we move on, I'd like to just pose a quick question to you. I wonder if you could talk a little bit about the role of partnerships in the growth of what you just described over the past few years, but also in particular looking forward. What do you think is the role of partnerships, and how will they help to scale and improve the types of solutions that you're talking about?
Yeah, I think when you talk about partnership, the partnership could be at a multiple levels. I think the first partnership is among the people with the diseases who have got different components. You've got Diabetes Association, you've got Cardiovascular Association, you've got Respiratory Association. So getting them together under one sort of a umbrella, which is the NCD Alliance. The second partnership is with the key stakeholders, which is the Ministry of Health and the Ministry of Local Government. The third partnership is with other stakeholders outside the sector of the Ministry of Health, with the other ministries which are responsible. And then fourth is what you have is the partnership with the research institutions, with the universities, at the same time ensuring that all the other stakeholders coming from the different sectors are also sitting together. And I think if you want to have a sustainable program, involvement of this partnership, not as and when you require, but right from the genesis of the program, making sure that you involve all of them when you are conceptualizing the program, and when you are implementing them, give them an update on a regular basis. That is what basically will be a good sustainable partnership.
That makes sense. Terrific. Thank you so much. And thanks for your presentation as well. It was really, really interesting. Okay, so it's now my pleasure to introduce the next session with a panel discussion on ways to accelerate diabetes care and prevention in low and middle income countries. So please share all your questions in the chat as we go through this session. We'll be monitoring it really closely, and we'll be happy to pose some select questions to the panelists as we go through. So we're very lucky. We've got 4 knowledgeable panelists on the topic with us. I'll do a brief introduction and then we'll go through each of them with some remarks one by one. So first is Ms. Aigerim Zhaparova, a diabetes advocate and in-country coordinator for Kyrgyzstan at IML-RED, a research institute on tuberculosis under the WHO supranational laboratory of TB. Second will be Dr. Noel Somasundaram, consultant endocrinologist at the National Hospital of Sri Lanka. Third will be Mr. Andrea Atzori, the head of international relations with Doctors with Africa, QAM. And finally, we'll have Dr. Cristina Parsons Perez, the capacity development director at the NCD Alliance. So again, please ask your questions in the chat. I'll monitor it closely and we'll be sure to direct your reflections to the panelists. So first up is Ms. Aigerim Zhaparova. She's living with diabetes and experienced in leading patient-centered projects and advocacy efforts for improved diabetes care. So Ms. Zhaparova, thanks so much for joining us. I feel like with your personal and also professional experience with diabetes and advocacy, perhaps you could talk to us about what you believe is the best approach to engage people living with diabetes in strengthening diabetes care. Over to you.
Thank you, James. As a little bit of context, I have been living with diabetes for 22 years now. And growing up, I really took pride in making diabetes invisible. And I was continuing living that way up until the point when I came across the International Diabetes Federation summer camp for leaders with diabetes. And I think it was sort of a critical juncture for me when I saw that fellow patients with diabetes actually are committed to improving the lives of patients and making sure that diabetes care is strengthened in their respective countries. And for me, I guess it was very eye-opening. And from that point on, I decided to involve myself with the local diabetes community. And I think this is when I really realized that in order to improve the diabetes care, we have to put the patients in the heart of the decision-making process and give them the agency over their health. Because this is when we will see the actual changes happening. And from the experience of managing World Diabetes Foundation grassroots project implemented by the local NGO in Kyrgyzstan, Childhood Without Diabetes, we have noticed that giving the agency, as I've mentioned, to patients and the caregivers actually brings a lot of benefits and improves health outcomes. As one of the examples, so we organized Diabetes Summer Camp, where we involved teenagers and adolescents with type 1 diabetes and made sure that they are sort of taking care of younger children. And I think this experience really instilled a sense of responsibility, and that they are actually able to have this choice being and making a difference. Yes, after the summer camp, the HB1AC levels dropped, and we could see that we could measure the health improvement of our beneficiaries. So I think it's one of the many examples which sort of testify that providing this choice of the decision making to patients, because we do know what matters to us and what we need in terms of everyday health needs, but at the same time also having and being involved in policy making and on a more sort of macro level. So I think, yes, this is pretty much empowering patients and giving them the opportunities and creating the opportunities where they can demonstrate that they are committed. So, and I think this will sort of create a very beautiful ripple effect, which would motivate other patients as well. So, thank you.
Thank you so much. I really appreciate that, especially sharing your expertise, but also your personal story. We really appreciate it. Feel privileged that you shared that with us. Okay, I'll move over now to Mr. Andrea Atzori, who has extensive experience through his work with QAM in promoting health across Africa, also in enhancing the care of prevention of NCDs. Mr. Atzori, your organization is present in several sub-Saharan African countries, building healthcare capacity through a variety of partnerships. Could you share with us what you believe needs to be in place to integrate diabetes and NCD care into existing health structures, especially at the primary care level?
Thank you, James. As you mentioned, Doctors with Africa, QAM, is working in a number of African countries. And the first thing we look at is the local partners. So the first partnership we look for is the system, the local health system that can absorb any capacity building program, technical assistance, in order to grow with our support. That's why we call Doctors with Africa and not for Africa. And that's the first point. The second point, the mission of QAM is the health system strengthening. So we want to put at the center of anything, even diabetes care, the local capacity, and especially the human resources, the professional. They are the frontline people that deal with people with diabetes eventually. And in doing that, as said the professor before, integration is the key word for us. So we think that strengthening diabetes care and prevention is a great opportunity for health system to improve their primary care, the secondary care. We heard before how much diabetes care is interconnected with anything, basically, from chronic diseases, but also surgical intervention for diabetic foot, for example, eye care. So it's a great opportunity to see the system as a whole, look in a specific disease, but let him, grow the system in a way that at the center there is people, families, and especially the prevention package. The other things that we are looking in each country is to move along all level of the system. We want to start from primary, secondary, and tertiary. I don't think there is much point here in telling somebody that some, diabetes type 2 condition or a diabetic foot and not having any connection with the secondary care or someone that can treat that wound, that can provide some surgical. So really, I think we have to look for the whole level of the system, the continuum of care, as is expressed in many papers, should be put in place. And this continuum of care inside the system must be strongly connected with the community. The last speaker said it very well. So we think that any program we devise, we've been partnering with WDF for 5 years now. We've been partnering with the Ministry of Health of Sierra Leone, Mozambique, and Angola, and Ethiopia in diabetes care, as a strong component of prevention information. So we have to be very bold on this. We need to seek patients at the very beginning, put them on treatment, follow them over the lifespan, and it's a big challenge. So really, even if we achieve a very nice health system, we need to look for the communities. We need to be very active in the community, and not actually we need external intervention, but as we heard before, probably with local activism, peer-to-peer, having also brighter day in conjugating, for example, peer-to-peer support groups that have been learning from other diseases to become also diabetes activists. So there is lots of opportunity for integrate, for leverage on experience that's been done in community and bringing diabetes care higher in the agenda. Finally, of course, as an international NGO, we do lots of advocacy because we want resources to be mobilized. We have an incredible example of, again, integration where, for example, the WDF program in Mozambique was matched by the Italian cooperation over 3 years. So we had a bigger program, and better outreach. We were able to do more community mobilization and put more people on treatment, thanks to two donors sharing the same agenda and putting at the core of this program the Ministry of Health. And it's, I mean, all the level of the Ministry of Health up to, for example, in Mozambique, they are called APES, so the community activists that are then referring people to an health system that is able to provide care for them. And finally, also we need innovation. For example, in Angola was the very first program with WDF and the Ministry of Health Angola. We integrate tuberculosis clinic with diabetes screening. Why? Because there was a very large influx of people in this clinic. It was a great opportunity early in the morning, you know, to inform them, and then the day after to check the glucose in the blood. So we've been doing pregnancy. We integrate antenatal clinic in Sierra Leone with diabetes screening. And there was another brilliant example done in partnership with the local authorities. So I want to stop here, but I think that, again, partnership with the local ministry, the ownership is very important. Health system strengthening and integration at all levels are the key messages for me. Thank you.
Thanks so much. That's really interesting. And I might come back to you with a couple of questions on that a little later on. Now over to you, Dr. Noel. So we know that you've been playing a pivotal role in laying the foundations for future diabetes care in Sri Lanka and reducing the overall burden of NCDs. Can we ask you, through your experience with primary and secondary prevention, could you provide some examples of successful initiatives and think about what we can learn from those?
Thank you, James, and thank you for the opportunity. It's usually in the NCD landscape, because it's so complex, there are needs for primordial and primary prevention, because unless we have healthy mothers who give birth to a healthy baby who then grows up without overweight and without unnecessary dietary advertisements and unnecessary pressures from the media, and if that adolescent grows into a healthy adult and continues to live well, then that person can prevent diabetes. And on the other hand, if a diabetes person gets diagnosed with diabetes early enough, and because diabetes is also so tricky because it has a silent period during which the patient is asymptomatic and does not realize that they might get complications unless diabetes is treated early. As you can see, this landscape is complex. And so we've devised with the Ministry of Health and other partners like NGOs, Primary Level Diabetes Foundation, a method to target multiple methods that are cost-effective and can be implemented nationally. And so with WDF, we have implemented a program where, for example, we have trained and capacity built more than 25,000 adults and touched more than 1 million adults just through WDF-based programs, but also with the help of the Ministry of Health and in partnership, try to influence almost the entire population. So how we do that is to bring about policy decisions like sugar tax and color coding of beverages, for example, to make it simpler for adults to, even with lower educational level, to understand that some of the food that is sold is unhealthy and can lead to non-communicable diseases. We also work with capacity building the existing staff who care for young women in family planning and also for antenatal care to counsel young women to become healthy mothers who will give birth to healthy babies, and also train them to talk about childhood nutrition right from the weaning period up to then they are adolescents, so that these seeds are planted early enough. We also work in WDF funded projects in schools to create newer ways for primary grade children to look at their diet innovatively, such as diaries, just painting their pictures, and we collect that data and then show them stories of how role models, such as cartoon figures, can have options of healthy as well as unhealthy choices and make it fun for them to understand and grasp those principles, and then collect the data back again in the form of painted diaries of food, and have shown that even such interventions that are simple and can be used in primary grades are very effective. On the other hand, we have also worked with the Ministry of Health in Sri Lanka to implement what is called the screening program in the healthy lifestyle centers, where population above 35 years of age is offered free screening, not just for NCDs, but also for cancers and early treatment, where this gap is existent at the moment, where patients, unless they have developed a complication or symptom, do not seek care or do not continue treatment. And we try to target that population to prevent complications. Of course, we also work in secondary and tertiary care for food care and others, but then it's a bit too late and it's more cost intense. And therefore, we concentrate not just on secondary and tertiary care, but also, as I said, in the lifestyle model of prevention of primordial, primary, early detection of diabetes, and then treatment.
Thank you so much. That was really valuable input. I think what we'll do is we'll move on to our final speaker, and then we'll come back and share some of the questions from the chat and some of the questions that we had. So I'd like to move on to Dr. Cristina Parsons Perez, who's the Capacity Development Director at the NCD Alliance, where she is responsible for strengthening national and regional civil society to drive NCD prevention and control. Dr. Parsons Perez, the NCD Alliance works across sectors through the lens of civil society and with both local and global stakeholders. So can we ask you, from your experience, how can civil society bridge the gap towards the global NCD targets, from shaping policies to actual implementation and action on the ground? Over to you.
Thank you, and good afternoon. It's a pleasure to be joining you today, and I'd like to just start by congratulating WDF, a partner of the NCD Alliance, for its 20th year anniversary. But to answer your question, James, I would say that at the NCD Alliance, we believe that a strong, vibrant, and mobilized civil society that is rooted in the community, with people living with NCDs at its core, is essential to drive national progress and meet the global targets. And we believe that civil society can help accelerate action to address key gaps in the NCD response, for example, prevention, care, financing, and community engagement. Now, coalition building is, and this speaks to partnerships as well, which I know is the theme of the forum today, coalition building is a really important element of a strong NCD civil society, having different civil society organizations working together towards a clear shared agenda. And so in the NCD space, what this means is bringing together organizations working across the different non-communicable diseases, risk factors, and even broader, and even organizations working in broader health and development issues. Now, NCD civil society, we believe, plays 4 main roles in accelerating the response, what we like to call the 4 A's: creating awareness, improving access, advocating for action, and ensuring accountability. Creating awareness, so this is where we see civil society looking to increase knowledge, seeing changes in attitudes or beliefs, building public demand, and really placing an issue on the public agenda. And this, of course, is a really important precursor for advocacy. Improving access, initiatives when needed, where we see civil society organizations looking to strengthen health systems, addressing health inequities. And I think we've heard some good examples today already, and I can see some in the chat as well. Advocacy work to really drive systemic change and influence policies, legislation, funding, And finally, this point on ensuring accountability and seeing civil society call out for translation of those global targets and commitments into national action, calling for implementation of policies that may already exist and calling for that implementation. And so, for example, using shadow reporting. So ultimately, civil society monitors and has a role, an important role to play in monitoring national progress and calling for improvements. And so civil society, by delivering on its main roles, is a critical element for an effective NCD response. Thank you. Back to you, James.
Thank you so much. That's terrific. So what I will do in the last couple of minutes is pose a couple of questions to our panelists. So perhaps which have come to us via the chat and also directly. So perhaps Mr. Atzori, maybe I can start with you. The question from the chat was, what are the main challenges in promoting health and education rights of children living with type 1 diabetes in low and middle income countries?
Well, there are many challenges. I think one of the main challenges, for example, when you talk about diet, is to make sure that you're talking with people that have alternatives. So you have to find a way in which they trust you, but at the same time, the message you give is feasible. They can change their behavior, they can change their diet. Otherwise, you have to broaden the partnership, including not the health sector, but some other sectors as well, in providing what is needed. The second point is that we really need to make sure that we are talking the same language, let's say. So really strengthening the message through local trusted people, local authorities, villages that have a chief of village, for example, in certain areas, or using existing network. For example, we had a brilliant example in Mozambique where there is a high HIV prevalence, and they have a lot of peer-to-peer support group. Now, a number of these organizations have been trained, and they also do diabetes prevention and education, and not just talking with a single disease, but it become more broader. So I think that that could be another example that we can leverage resources for overcoming barrier in educating people and promoting prevention of diabetes.
Excellent, thank you. Maybe I'll whiz on to the next question as well. Perhaps Dr. Parsons Perez, can I come back to you? You mentioned the importance of civil society building coalitions and shaping policies in the global agenda. Could you talk a bit about how civil society coalitions should be engaged in the implementation of national level NCD responses?
Thank you, James. I appreciate that question. And I think to start off with is this idea that there is global political recognition of the need for a whole of society approach on NCDs. And as part of that whole of society approach, where we see, of course, government, private sector, academia, multilateral organizations, civil society is a key player. And so how, so what we spoke, I was mentioning earlier the key roles that civil society can play to accelerate action on diabetes and NCDs. So there's a key question here, right, which is how. So what is needed to kind of leverage this strength and power and potential of civil society and communities? I think the first point relates to civic space, and we're actually seeing an alarming shrinking of civic space globally. So this is the notion that civil society really needs supportive legal, social, and policy environments in order to thrive. So we really need to see governments fostering and expanding that civic space. We need more investment to sustainably finance civil society and community systems. We're hearing of a lot of great work actually at WDF in building capacity and helping, kind of professionalize civil society. But this is something that we need to see kind of different stakeholders in the NCD response recognized. And I think this also kind of ties in with broader discussions on financing for NCDs, but seeing investment in civil society as a priority and a global public good. And I think this point that touches upon a little bit what we were hearing from Aigerim earlier about the agency of people living with NCDs and the need for meaningful involvement, and that is that meaningful involvement and engagement, certainly of civil society and of people living with diabetes and of NCDs, cannot be a tokenistic effort. So this is where civil society organizations and individuals with lived experience are seen and recognized as equal partners and experts in their own right. And so this is really calling out for the need for spaces, for participation, for civil society to be able to input and share in decision making from the very beginning of design and planning stages all the way through the end. Thank you.
Brilliant. Thank you for that answer. Quickly, we'll move on to the next question. Dr. Noel, a question from the audience. And if you don't mind, I'll ask you to be very succinct, perhaps in 30 seconds, if that's possible. How do you increase access to medications and devices in a system where people still pay medical bills out of pocket?
Yeah, it's an interesting and difficult question to answer. Fortunately, Sri Lanka has a 50-50 system where 50% of the population comes for state-sponsored. Even if it is free at the point of delivery, it is still people paid for and pocketed out system. So even when we say the system provides for the medication in low middle income countries and poorer countries, it is still pocketed out by the public themselves. And so therefore, this is a difficult question. Perhaps what we can think about and what is feasible is to think about making these systems more cost effective. And looking at, that is what I was referring to earlier, by making going for the best buys, because the most effective interventions in the society is to prevent diabetes and to treat it early, because the cost of a complicated diabetes and its treatment, whatever system they are in, is about 1,000 times more than if you were to do prevention and intervention at the early stages. And I think that is the best way in which low middle income countries have to go forwards, and even the richer nations wouldn't be able to care for all the diabetes complications if these are not treated for. And therefore, systems put in by government in terms of policies and early screening offers and treatment offered at the early asymptomatic phase before complications have occurred will be way more cost effective than if they were to be developing complications and then the system has to intervene with antibiotics and amputations and then prostheses and so on, can have devastating consequences for the society, whatever the society is. And so there is no real answers, but I am a believer in early interventions in communities, particularly with policies that bring about prevention and real meaning to the intervention that we do.
That's right. Thank you so much. And perhaps Ms. Zhaparova, maybe I can come back to you for one final question from the audience, which was, how can we empower families from low-income families to develop income-generating activities to support their children? And again, I apologize, I'll ask you to be really concise with your answer.
Sure, thank you. Well, I think the events, for example, on fundraising and how to basically mobilize the resources could be very effective. And this is what we've done in our project, where we were inviting families who were struggling financially to support and care for their children. That fundraising could be one of the ways to mobilize the resources. So I think in terms of the ways how to get the funds, I think it's also a work with policymakers, and I think the activists could be actually involved in these processes on exploring alternative financing mechanisms and looking how the healthcare is financed, and maybe redistributing the resources that could be used elsewhere.
Great. Thank you so much. And thanks to all of our panelists actually for joining us and for sharing their expertise with us today. We're running short on time, so I'm going to really quickly say thanks for joining. For our closing remarks, I'll hand over to Dr. Anil Kapur. Over to you.
Thank you, James. Thank you for conducting the panel discussion in a very professional manner. And I'd like to thank Dalberg for organizing this webinar and the Secretariat of the World Diabetes Foundation to get everybody together. Also, I'd like to thank the panelists for their wonderful comments and remarks and bringing about the understanding of the issues at the ground level. It has been over the last 20 years our endeavor in the World Diabetes Foundation, as I mentioned earlier, to catalyze change and to make our local partners the heroes. We believe that until and unless the projects are owned locally and are developed locally and are implemented locally with local knowledge, we would not be able to make them sustainable. And therefore, I'd like to thank all our partners over the many years for the wonderful work that they have been doing. I'd also take the opportunity to thank my colleagues on the board of the World Diabetes Foundation for the support, the encouragement, and great discussions that we have to ensure that the foundation remains grounded and is able to do something that is meaningful. As was also very obvious from the discussion of the panelists, that many of the things that I mentioned earlier in terms of how a small foundation like ours, starting with the actions on diabetes, is able to work towards increasing its impact in terms of ensuring involvement of the health system, ensuring that other diseases are not left behind. When we build a system for diabetes, we're building a system for NCDs. When we deal with diabetes, we cannot deal with diabetes alone, and we have to deal with many other things. And therefore, it is wonderful that many of these things that were mentioned by the partners actually showcase what the World Diabetes Foundation has been doing. So thank you very much, all of you, and also the partners that I cannot name all of them, both at the local and global level, for being part of this journey of 20 years of the World Diabetes Foundation. Thank you very much. And also, I'd like to end by saying a great thank you to our funders, largely Novo Nordisk, which has provided the funding for the World Diabetes Foundation to do these activities, and of late, the Novo Nordisk Foundation that has also contributed and allowed us to bring about a much bigger impact of our work. Thank you very much.